doing a brief case presentation, doing the case presentation briefly, like get through it.
Yeah.
So that we've had a chance to talk about it and other people will trickle in.
Sure. Yeah, that's fine. Like I said, I do have a good stopping point. If we don't get through all of it, I can certainly stop and we can pick it up later. So
yeah. Right now my view shows launching. Let's see. Okay. So
all right, good morning, everyone. Thank you for joining us bright and early today on a Monday. I hope everyone had a wonderful holiday break and Happy New Year to you all. So why don't we go ahead and get started with some introductions. And why don't we start with Allison? Would you like to start?
Sure. I'm Allison Sela. I am the pulmonologist at Preston Memorial Hospital in Kingwood, West Virginia, and I'm also the consulting pulmonologist for this group, the APHP.
Perfect. Thank you so much. Dr. Doyle, would you like to introduce yourself?
Dan Doyle with River Health in Cabin Creek, and I'm at home this morning.
Thank you. And Tara?
Good morning. I'm Tara Miller here, respiratory therapist at the Grace and Dorney Pulmonary Rehabilitation Center at Jackson General in Ripley, West Virginia.
Thank you. And Dean? Dean, are you able to hear us?
My name is Dean Gunner. I'm from Pocahontas Memorial Hospital, respiratory therapist, and I got Caitlin Sharp. She'll be in and out of here too.
Great, thank you.
Thank you.
And Eric?
Hi, I'm Eric Stockton with the Dorney Koppel Foundation, based here in Washington, D.C.
Great, thank you so much. And Grace Ann? Okay, so she may not be able to hear us, but we can go ahead and chat her as well. And there's one with a C.D. Carpin.
Yes, it's Diana Carpenter with the Rural Health Model. Good morning.
Good morning, thank you. Krista Clark.
Good morning. This is Krista Clark and Katie Sigmund. We are at the Cabin Creek Health Systems Breathing Center. We are both respiratory therapists in the Pulmonary Rehab Program.
Great, thank you guys for joining us. Caitlin Grados.
Hi, this is Caitlin Grados from UPMC Altoona Black Lung Clinic. And Renee Henry from UPMC's Black Lung Clinic.
Great, thank you. And there's a B. Bell.
Good morning. This is Brandy Bell at Lincoln Primary Care in Hamlin, West Virginia, and I am a respiratory therapist at one of the Grace and Dorney sites.
Great, thank you. And Kay Mastel.
Good morning, Krista Mastel. I'm the program coordinator for the Black Lung Clinics program at HRSA.
Thank you. And we have a phone number. It's 304-919-3923.
Hi, this is Kim Keenan with the Benedum Foundation.
Great. Hi. Thank you so much. All right. And hi, I'm Mitra Motasham. I'm an Project Echo coordinator.
Hi, everybody. I'm Caitlin Edinger, the other Project Echo coordinator.
All right, thank you. So why don't we go ahead and get started with the didactic, Allison. We were saying maybe we can start with that. So anytime you're ready, we can go ahead and pull that up and get started.
Dr. Doyle, did you want to start with your case presentation?
I'm going to flip-flop again. Seems like we've got pretty good group of people here, and some might still trickle in, but we got a great group, so why don't you go ahead?
Okay, all right. So I'm going to go ahead and share my screen. Can you see my screen?
Yes.
Yes.
Okay. Now I do have Maura with me, so I apologize. I'm going to try and keep her as quiet as I can, but being as it is, she's with me today. So, all right. So, as I said, my name is Allison Sela. I am the medical director for intensive care and cardiopulmonary services at Preston Memorial Hospital. And I was asked to speak today on the NICE guidelines for COPD. And so the formal name for those, what they call them is chronic obstructive pulmonary disease in over 16s, diagnosis and management. And this again is the NICE guidelines, or the National Institute for Health and Care Excellence, which are the guidelines that they use in the UK. So today we're going to talk about diagnosis, managing stable disease, and managing exacerbations. And then I do have a slide at the end about some of the things that I found sort of unique and greatly different than what we do with the GOLD guidelines that we use here. So symptoms, usually they use about the same symptoms that we use here. They're looking for exertional breathlessness, chronic cough, sputum production, frequent what they call winter bronchitis, and wheezing. And they look for this in patients that are over age 35 with a risk factor, and that risk factor usually being smoking. They recommend that physicians ask about weight loss, reduced exercise tolerance, waking at night with shortness of breath, swelling, fatigue, occupational exposures, or other risk factors, as well as chest pain and hemoptysis. And when they look for chest pain and hemoptysis, it's because these are uncommon in COPD and should cause you to think about something else being your diagnosis. And again, I do want to point out that these guidelines that I'm going to be talking about today are for their primary care doctors, because the health system is set up a little bit different in the UK, probably more like it's set up here in rural West Virginia, honestly, where there's not a specialty pulmonologist right around the corner, and that these diseases are being managed for the most part by the primary care physicians. So, what they use to determine dyspnea is something called the Medical Research Council Dyspnea Scale, or the MRC Dyspnea Scale. We've talked about this in the past. The one that we use here is the Modified Medical Research Council Dyspnea Scale, or the MMRC. And this is the original one and the one that they recommend using. And they classified the dyspnea from grade 1 to 5, with 1 being not troubled by breathlessness except with strenuous exercise, and 5 being too breathless to leave the house, or breathless when dressing or undressing. What they recommend is that at diagnosis, you should perform spirometry. You should also perform it again if you need to reconsider the diagnosis. For example, if your patient were to show good response to treatments, and then also to monitor disease progression. And again, I think these are the times that we are also performing spirometry here. They do recommend a post-bronchodilator spirometry to confirm COPD diagnosis. And then they do give some times where you should think about alternate diagnoses. One of the things that they mention, which is in alignment with our goals, is that all healthcare professionals who care for people with COPD should have access to spirometry and be competent in interpreting the results, and that anybody can perform it as long as they've had appropriate training and they're up to date in their skills. Quality control processes should be in place and reference values should be used, and we do both of those. So one of the things that they recommend is that if patients have some signs of emphysema or chronic airway disease on their chest x-ray or CT scan, that they should have further review. They say that if there are some findings on your imaging and the patient is a current smoker, that they should be offered smoking cessation. They should be warned that they are at a higher risk of developing lung disease. They should return to the clinic if their respiratory symptoms develop. And they should be made aware that emphysema is an independent risk factor for lung cancer. In patients who are non-smokers with incidental imaging findings, they should be asked about their personal or family history of liver or lung disease, as the possibility of alpha-1 antitrypsin may be their diagnosis. They should be reassured that their emphysema or chronic airway disease is unlikely to get worse. And then the same last two, that they should return if they develop respiratory symptoms and should be aware that the presence of emphysema is an independent risk factor for lung cancer. At the time of initial investigation or diagnosis into COPD, they should also have a chest radiograph just to exclude other possibilities. They should have a full blood count to identify anemia or polycythemia, and they should have a BMI calculation performed. The next slide is a list of other possible investigations that the patients may need, depending on the history that you obtained from them during their exam. For example, if they have persistent purulent sputum, you would want to consider a sputum culture. I'm sorry. If they...
Allison, if you'd like to switch to the case for a little bit and come back to the didactic, we can certainly do that as well.
Okay, give me just 1 second, okay?
Sure, no worries.
I am so sorry, guys.
We'll just do the case for like 10 minutes and then come right back to this. Okay, we'll leave it on your screen and just stop sharing on our end.
Give me just 1 second. I'm so sorry. She's been quiet all morning.
At all, yeah.
All right, let's go ahead. Give me 1 second. Do you want to go ahead and switch to the case? See if I can get her calmed down a little bit.
Sure, why don't we do that? Allison, why don't you mute? We'll do the case.
Yeah, give me 1 second.
And Allison, just wave or something when you're ready to come back.
All right, perfect.
And Lisa, I see that you're here. Lisa Emery, great. I'm not going to put on you to present this case, but you know the patient, so get ready to help out if you have comments. Can you put the case up, Mitra?
Sure, absolutely. Are you all able to see that okay?
I can see it.
Yes, I can see it.
All right, perfect. Thank you.
So we're going to try to, I'm going to try to get through this case quickly. Easier said than done, but so that it's easy for Allison to come back when she's ready. But in some ways, this situation is a classic situation in pulmonary rehab because this was a visit that was done for a patient who was ready to start pulmonary rehab. The respiratory therapist, Lisa Emery, had prepared him, done his intake, and our protocol is that before the person actually starts exercise, they have a physician visit. We call it pulmonary rehab medical clearance. And so I saw this patient on December 30th because Lisa had done his intake and he was ready to go. And it was time for his provider visit before he started exercise. And if you go down, Mitra, to that thing that says HPI, there you go. This is a 59-year-old retired and disabled coal miner. This is the first time that I had ever saw him. Correct me if I'm wrong, Lisa, but I believe his primary care provider was not within New River Health, but was at, oh, actually, this patient was interesting. He didn't have a primary care provider. When I asked him who was his PCP, he said nobody. He had a pulmonologist, and And his pulmonologist in Beckley is an excellent pulmonologist. Unfortunately, that pulmonologist is so excellent that he's in the hospital almost all the time doing consults and managing patients in the ICU. And so there's not real good primary care access in his office. So here's somebody who depends on his pulmonologist for all his care, but when he's sick, he can't get in to see the pulmonologist. So on this particular day, on the medical side, the reason for his visit was he's ready to start pulmonary rehab, he needs clearance. But on the patient side, he felt like he was sick and he was worried he was developing another exacerbation. So this visit wound up having a dual agenda, which was to evaluate him for pulmonary rehab, but also address his concern, which is that he was sick and he was afraid he was going to have to go to the emergency room or somewhere because he was having more dyspnea, more productive cough. Sounds like he had a case of winter bronchitis, is what they call it in the UK, and here we call it exacerbation, and the patients call it flare-up. He reported no known cardiac disease or cardiac events, but I noticed that on his CT scan that had been done by his pulmonologist as a low-dose CT, he had coronary arterial sclerosis, and also on EKG, he had chronic sinus tachycardia. He was a former heavy smoker, but he had cut down to about 2 to 3 cigarettes. Some places in the chart it said 2 to 3 cigarettes per day. Some places it said 2 to 3 cigarettes a week. He was up to date on his immunizations. He had last year federal black lung testing at Norton, Virginia, which is very thorough with exercise blood gas test, chest x-ray, examination. He did then receive federal black lung benefits. The next thing you see on the screen says CLD profile, chronic lung disease, and that's something that we designed at Cabin Creek and New River and that I've been trying to consistently use, which is a 9-item sort of thumbnail sketch or overview of what we think are critical elements in a history of a patient with chronic lung disease. And so we try to keep this up to date and paste this in to the history of present illness for each progress note. So the first thing on the list is who's their doctor? And you can see there it says PCP non-pulmonologist Dr. Haddadin. Next thing is what's their diagnosis? Co-workers pneumoconiosis with federal black lung benefits, COPD, severe emphysema. And I put in possible pulmonary hypertension. Tobacco, well, this is a mix here. Former heavy smoker, but still smoking a few cigarettes per day. 6-minute walk test, over 1,000 feet. MMRC, stage 3 on our scale, which runs 0 to 4. Spirometry showed severe obstruction with significant post-bronchodilator improvement, so that many of our pulmonologist friends in the country might label him as ACOS, which is asthma COPD overlap syndrome. His chest x-ray shows definite pneumoconiosis. There were some macular changes or confluent masses that got him into having repeat CTs with worry about some kind of mass. I saw your note, Caitlin, about what is MMRC, and it stands for Modified Medical Research Council Dyspnea Scale. And that was one of the first or second slides that Allison showed in her presentation that she got into. It's just a big fancy name for a dyspnea scale that ranges from 0 to 4 or 1 to 5, depending on which version you use. His EKG was good, and I wanted to have a copy of it here, but Lisa and I didn't have time over the weekend to get it to Caitlin, so you're going to have to take my word for it. The EKG is normal, except for tachycardia at a heart rate of about 120. And the other thing that we're trying to consistently include in our 9-item CLD profile is what is their gold, grade, and group. And for those, and and some of you are familiar with the GOLD, are very familiar with the GOLD guidelines, some of you a little bit, but I'm encouraging all of our sites to actually use the GOLD risk assessment or risk stratifying system on a regular clinical basis, which means we got to practice with it. The 4 stands for how bad their spirometry is, the severity of their spirometry, and the letter, and there are 4 possible letters, A, B, C, D, with D being the worst, are a combination of things. And really you need to print out the table that's in the GOLD guidelines and put it up on the wall to regularly refer to it. Whether their letter is A, B, C, or D depends on their dyspnea level or their CAT score in terms of symptom severity and their exacerbation history. No comorbidities that have been diagnosed, but as I said, we suspect that he has latent coronary arteriosclerosis. And then if you go back up, Mitra, this echo form kind of puts things in a different order than what we're used to, because it has the physical at the top, and we usually start with history. But you can see that his medicines are Spiriva, ProAir, Bria ellipta, and theophylline. Theophylline is prescribed by his pulmonologist. We tend to not use that very much anymore. And I just kind of had a aha moment here, realizing that theophylline could be a contributing factor for his tachycardia, which I confess I hadn't thought of till now. And then just go up a little bit more, and there's his physical exam. He's skinny, BMI 15, which is actually an independent risk, an independent prognostic factor in the Bodie scale for worse prognosis. And he had lost about 15 pounds this year. So slender, dyspneic, very articulate, well-informed guy. He was coughing some. Vitals, heart rate was 112, blood pressure good, sat good on room air. He does have oxygen at home and uses it at night. Very diminished breath sounds. It's one of those people you listen to the lungs and you feel like you're not hearing much, but he didn't have rales or wheezing. Heart rate rapid, otherwise normal, no clubbing or edema, and his neurologic was normal. So then if you go down, Mitra, to his spirometry, I'm just going to give people a second to look at those spirometry values. For those of you who don't have the screen and are listening on the phone, basically his spirometry pre-bronchodilator showed severe obstruction. Let's see, percent predicted FEV1 66. So actually we would call that, and if I'm misinterpreting this, somebody catch me. Just scroll up a tiny bit, Mitra. There you go. Okay, so his FEV1 1.26, that was 66% of predicted. So actually, by the GOLD severity guidelines, that's moderate. His FEV1 FVC is very low, but his percent predicted FEV1 puts him in a moderate obstruction range. His FVC puts him in a mild restriction range, which is probably pseudo-restriction of severe emphysema. And then his scroll down now, his post-bronchodilator, he had quite a bit of improvement, 30% improvement in his FVC and 13% improvement in his FEV1, but still he is in a moderate obstruction, mild restriction range. Any questions about the data presented here or anything that's missing in the data here that people feel like they need to know about this patient?
Confused. His percent predicted pre-bronchodilator was 66% and post-bronchodilator was 40%. Was it a negative change?
Okay, percent.
His percent predicted post-bronchodilator is 26%.
Okay, I must have put the numbers in wrong. Thanks.
So his FVC is 48% post-bronchodilator. His FEV1 is 26. His ratio is 43.
Did he have a negative change with bronchodilators?
Nope. No.
So the wrong numbers are in there. So
the wrong numbers are in. So if
he's 26%, he's very severe.
Yeah, his actual FVC is 2.23, which is 48% of predicted, and his actual FEV1 is 0.96, which is 26% of predicted.
Well,
Okay.
I know what the problem is here. I actually was putting this case in on Saturday, so we had something, and so I didn't have that spirometry, that current spirometry, so I used his spirometry numbers from Norton in 2018.
This
I think
yeah,
is the
this
reason
is
for
it.
this.
So
Okay, so what Lisa's giving us are more current numbers.
Yeah, so 26% predicted post-bronchodilator would be a very severe obstructive ventilatory impairment.
Right. Okay. Any other questions about the data or the presentation? Okay, well, what I would like to do is just go down a little bit more to just to sort of share what my questions were, but instead of getting into a big discussion of the questions, get back to Allison while the baby is sleeping. So the questions I had were, is his unexplained sinus tachycardia a contraindication to starting pulmonary rehab? I don't think it's an absolute contraindication, but at any rate, absolute or relative contraindication. What additional tests might be recommended before the patient starts pulmonary rehab? And how does his inhaler regimen correspond to the GOLD 2019 guidelines for a GOLD 4C risk category? And with that, I'd like to, it's okay, jump back to Allison.
I'm okay with that. Let me go ahead and share my screen again. Get her hypnotized by the fan, so hopefully we'll... Okay, so again, at the time of diagnosis, everybody should have a chest x-ray, a blood count, and a BMI, and then some possible other investigations as needed. For example, if they have purulent sputum, they should have a sputum culture. If there is still some concern about whether they have asthma, you can consider serial peak flow measurements. If there is any concern about cardiac disease, pulmonary hypertension, then some additional cardiac testing such as an EKG and natriuretic peptides should be checked, as well as an echocardiogram. If the patient has some type of symptoms that seem disproportionate to their spirometry, if there is possibly some fibrosis or bronchiectasis on chest x-ray, or any other abnormalities, then consider a CT scan of the chest. If patients are diagnosed at an earlier age, if they have minimal smoking history, or if they have a family history, consider serum alpha-1 antitrypsin testing, which is interesting that they recommend this, as you'll see why a little bit later. And then what they call a transfer factor for carbon monoxide, which is DLCO in our terminology. Again, if they have symptoms that are disproportionate to their spirometry, or if this is somebody that you would like to refer for possible lung volume reduction surgery. So the next section of the guidelines talk about reversibility testing or bronchodilator response. And they say that this is not necessary as part of a diagnostic workup or an initial treatment plan, as it may be unhelpful or misleading, just due to the natural history of this response being somewhat spontaneously fluctuating, being inconsistent and not reproducible. In their guidelines, they use 400 mLs or 400 cc's as their guideline to say what is a useful or a reversible bronchodilator response. And remember, in our guidelines, we use 200 cc's. So they're really looking for a big change with the bronchodilators. And the bottom line for this is that their response to long-term therapy is not predicted by their response to reversibility testing, which is something that we say as well. Just because they don't respond to bronchodilators doesn't mean that that's not going to be the case in day-to-day practice. And their point here is that undiagnosed COPD and asthma are often distinguishable based on their history and physical for these patients that are presenting for the first time. And this is some of the details that they use to differentiate the two diseases. Smokers or ex-smokers, usually common in COPD, but not so common in asthma. Symptoms under age 35, common in asthma, but rare in COPD. Chronic productive cough is more often seen with COPD. Breathlessness is persistent and progressive with COPD, but variable in asthma. Asthmatics usually have nighttime wakenings, and they also have significant day-to-day variability of their symptoms. And in order to differentiate from COPD from asthma, again, they are looking for that large, greater than 400 ml response to bronchodilators. They also will note a large response to an oral steroid challenge, which they really don't recommend doing, but I think it was something that was done in the past, where you would give 30 milligrams of prednisone daily for 2 weeks and repeat PFTs at the end. And if you see this, reversibility of greater than 400, that was diagnostic for asthma. You can also look for peak flow measurements that show greater than a 20% variability. They mentioned that if their FEV1 and their FEV1 FVC ratio return to normal with treatment, this is likely not COPD. If you're still uncertain, you can send them for more detailed investigations, including that TLCO measurement. And if they have a response to therapy, which I found this interesting, if they have a response to bronchodilator therapy, probably not COPD. And that's, something that I think as clinical practitioners, we see all the time, that your COPD patients come in and they're like, I'm not feeling any better, I'm not feeling any better. And for me, at least, I want to make the patients feel better. And so I'm always trying to switch their inhalers. But I think that this statement right here says that you're probably not going to see much of an improvement in your COPD patients versus in your asthma patients who should be having a response to treatment and should be feeling better with this therapy. So we'll go ahead and move on to severity and prognostic factors. No single measure can adequately assess disease severity, but it is important to try because this relates to how you're going to treat these patients and their prognosis for the disease. One thing that they did mention is do not use the multidimensional index like the Bode index to assess prognosis in people that have stable disease. And they did recommend using the following factors to try and determine their prognosis. Things like their FEV1, smoking status, the MRC scale, chronic hypoxia, low BMI, which Dr. Doyle alluded with his case presentation, exacerbations, and we've talked about this before, that people that have exacerbations are always going to have frequent exacerbations, and with each exacerbation, you're not going to recover fully to baseline, and you're going to have more and more severe exacerbations, and your lung function declines as well. And that goes along with hospital admissions. The more severe your exacerbation, the more likely you are to have to be admitted to the hospital for it. And then, the other things such as more comorbidities and frailty as well. This chart shows classification of COPD based on the original NICE guidelines from 2004, the American Thoracic Society and European Respiratory Society guidelines from 2004, the GOLD guidelines from 2008, and then the more updated NICE guidelines. And you can see that when they updated the NICE guidelines, they actually put themselves into alignment with GOLD and ATS, versus before they called what we call moderate actually mild disease, and they only had 3 categories of mild, moderate, and severe. And now they're in alignment with us with mild, moderate, severe, and very severe. So they did talk a little bit about how to identify early disease. They recommend performing spirometry in patients that are over 35 who are current or ex-smokers with a cough. Consider spirometry in people with chronic bronchitis, because a lot of them will go on to develop airflow limitation, and to refer to specialists as needed. And again, I think this is a little bit different than what we practice on a regular basis here in the United States, where most people are being seen by, excuse me, pulmonologists a little bit earlier, where in the UK, they are managing these patients, on the most part, in the primary care offices. Excuse me. They gave a list of reasons for referral to a pulmonologist, and I'm not going to read through all of these, but you know, what I would say is if they're uncomfortable with anything that they're dealing with, then refer to a pulmonologist that would have more specific training in that field. Excuse me. The next section is managing stable COPD. This is the diagram that was listed in the NICE guidelines, and I've made this bigger in the next couple of slides, so don't worry if you can't see this. So again, this first box here is things that we do. Fundamentals of care, like offering smoking cessation, offering vaccinations, pulmonary rehab if indicated, creating a self-management plan, and optimize your comorbidities. This should be done at every opportunity, every visit with the patient. Don't start inhaled therapies until you've done all of these things, and only start them if they are needed to relieve breathlessness. If you have a patient who's been diagnosed with COPD for some reason, but they're not really having symptoms, you don't really need to start any type of inhaler. And also, before you start inhalers, you should make sure that the patients have been trained to use them and can demonstrate satisfactory technique, which I think is part that a lot of us are missing. I know I certainly don't watch my patients take their inhalers in clinic, but I am lucky that I do have respiratory therapists that can come over and show them how to use their inhalers in clinic if I have some questions about how they're using them.
We had a quick question, Allison, in the chat. I was just going to quickly ask you. It was, what is in over 16S?
I think it means 16 years old.
Okay.
Yeah, that's how I would interpret it based on my time in England. So.
Perfect. Thank you so much. Sorry.
Oh, no problem. So the first step would be to offer a short-acting, like a rescue inhaler as needed, a short-acting broncho beta agonist or muscarinic agonist. If the person is limited by their symptoms or has exacerbations despite that treatment, and they have no asthmatic features, you would then go on to offer a combination inhaler of a LABA and a LAMA. Long-acting beta agonist, and I get into these terms a little bit more in the next couple of slides, but just wanted to break down the diagram for you. But you would offer a combination of a LABA and a LAMA. And then if they continue to have symptoms, you would consider a 3-month trial of a LABA-LAMA inhaled steroid combination. If they do not respond to that with that 3-month trial, you would go back to a LABA-LAMA combination. The other time that you would offer the triple therapy would be if the patient has 1 severe or 2 moderate exacerbations within a year. And then back up at the top of this diagram, if there are asthmatic features, the combination that they recommend is a LABA-ICS combination, which is what we do, which are the inhalers like Advair, Symbicort, Dulera, Brio, those combinations. And then again, if they have significant symptoms that affect their quality of life or exacerbations, you would offer them triple therapy as well, which is a little bit different because we do not regularly offer the LAMA therapy like Spiriva to our asthmatic patients. And if you try it,
remind us examples of what the LABA-LAMAs are?
Sure.
What are the brands of LABA-LAMAs?
Sure. So the LABA ICS, like I said, are things like Advair, Brio, Symbicort, Dulera, and those were the combination inhalers that we had for a long time. So I think the general convention was to go to those combinations when you needed to expand on therapy. But in recent years, we've come up with not only the individual agents for the LABA and the LAMA, but also the combinations. And the LABA-LAMA combinations are Stiolto and Anoro are probably the two biggest ones that are used. And then the only inhaler we have on the market now that is a triple therapy in one inhaler would be the Trelegy. But you can certainly use things like Stiolto or Anoro with a Flovent or a Pulmicort or something like that to get to that combination.
Right, and there seems to be a tendency, probably in response to marketing, to skip that second step of LABA-LAMA and go straight to Trelegy now that it's available. I think we should discourage our folks from doing that.
Yeah.
And not partly because of expense, but partly because it's exposing people to the side effects of inhaled steroids instead of giving them a chance on Stiolto or Anoro Ellipta.
Correct. And that's certainly not what the GOLD guidelines indicate that we should be doing. So if we're following guidelines, whether we're using the NICE guidelines or the GOLD guidelines, neither of them say that you should go directly to triple therapy. So, but you're right, the marketing is pretty strong. So, okay, I'll go ahead and move on here. So again, if we go back to this diagram, we're looking at the dark gray box on the top left. And the first step would be to discuss smoking cessation. So smoking cessation should be documented. You should offer advice and encourage them to quit, offer tools to help them quit, whether it is classes or nicotine replacement or varenicline or bupropion or which is Chantix or Wellbutrin as appropriate for these patients. And they do actually get into additional guidelines for who should receive Chantix, which I didn't get into with this presentation because we were already covering quite a bit of information, but it is there. Inhaled therapy, again, the first step is a SABA or a SAMA, which would be things like albuterol or Xopenex, use as necessary to relieve breathlessness and relieve breathlessness and exercise limitations. So you can use it on an as-needed basis or on a scheduled basis prior to exercise, which is what we do here as our first step generally. Inhaled corticosteroids, they made a mention again to not use oral corticosteroid reversibility test to determine use, and that was where I mentioned earlier where they would give 30 milligrams of prednisone and over 2 weeks and then see how they did, which was something I think that they did in the past, but they found that these tests do not predict response. And again, as Dr. Doyle alluded to, be aware that the inhaled corticosteroids do have side effects, and these should always be discussed with the patient prior to starting. Common side effects include things like thrush, increased cough are probably the two most common, and then also the increased risk of pneumonia for patients that are on especially high-dosed inhaled corticosteroids. Inhaled combination therapy refers to any type of combination of the LAMA, which is the long-acting muscarinic antagonists, the LABA, the long-acting beta-2 agonists, and the ICS, or the inhaled corticosteroids. And again, you don't want to use just the response in spirometry, but you also want to use things like how are their symptoms improving? Are they able to do more activities of daily living? Has their exercise capacity improved? And how quickly do they get relief? So for patients that have spirometry confirmed COPD without asthmatic features, you would first consider that LAMA-LABA as your combination. But if they remain breathlessness, then you would consider adding triple therapy. When you would consider adding this combination to your short-acting medications as if these patients have been treated for tobacco dependence. So again, in the UK, they're a little bit more paternalistic, maybe would be the right word, that if you don't, if they don't want help with their smoking cessation, they actually recommend not giving them inhalers. So if they have used treatment for tobacco dependence, if you've optimized their non-pharmacologic management, and if they're already using a short-acting inhaler, then you would consider adding the long-acting medications. They did mention that if there are people that are using inhalers outside of the guidelines, that it is okay to let them continue to use those inhalers until they have agreed with their healthcare provider that it's appropriate to change medications. And basically, you know, the next step would be to add that inhaled corticosteroid to the LAMA-LAVA combination, and again, make sure that their non-pharmacologic management, including tobacco cessation, has been met. Ensure that their worsening is caused by COPD and not some other medical condition, and ensure that their day-to-day symptoms are impacting their quality of life. Again, if they are breathless but it's not affecting their quality of life, they don't necessarily recommend adding more medication. And the other reason to add triple therapy is if they have those hospitalizations, either one that is severe enough to require hospitalization, if they're having exacerbations, either one that's severe enough to require hospitalization or two moderate exacerbations, which would require a change in medications or treatment with steroids and antibiotics outside of the hospital. And if they do a 3-month trial and they respond, that's great. You can keep them on that medication. If they don't really notice a benefit, they recommend switching them back to just dual therapy. Again, in the UK, you know, considering costs and how healthcare is provided and paid for, they don't want to waste any additional money. When patients are on inhaled therapy, you need to review them at least annually. You want to base your choice of drugs on their improvement in symptoms, their preferences, the ability of the medication to reduce exacerbations, any side effects that may be present, and the cost. Excuse me. They want you to minimize the number and the type of inhalers as much as possible. You know, the number and the is going to improve the patient's compliance with the medications. If they only have to take 1 puff once a day versus 2 puffs of 3 separate inhalers twice a day, they're going to be much more compliant. And same thing goes for the types of inhalers. If they have to learn and master 3 different types of inhalers as opposed to 1 dry powder inhaler or 1 MDI, they're going to be much more compliant with fewer types of inhalers. And again, something that's important for all of us to remember is that all of our patients need to be trained on how to use these inhalers. Delivery systems, they go into depth about inhalers, spacers, and nebulizers. Like our guidelines say, most drugs are best administered using a handheld inhaler plus or minus a spacer. They just need training, and you need to make sure on a regular basis that they still are using these medications correctly. Nebulizers, they recommend using if they've got distressing or disabling breathlessness despite maximal therapy using their inhalers. And you need to make sure that if they're using a nebulizer that they are getting a benefit from it, and if they aren't, they recommend going back to the handheld inhalers. They do recommend giving a choice between a face mask and a mouthpiece. Going on to oral therapy, they do not recommend long-term corticosteroid use, which is in alignment with the GOLD guidelines. If you do need to use them, use the lowest possible dose and monitor for osteoporosis. Theophylline, use only in patients that are unable to use inhaled therapy due to your need for monitoring their levels and the interactions, particularly in elderly. Again, you want to assess and make sure that they're effective. If theophylline is not working, you know, don't continue to use it. And then reduce the dose if the patients are on macrolide or fluoroquinolone antibiotics for exacerbations. They recommend the use of mucolytics in patients that have a chronic cough productive of sputum, and then Continue if patients see a benefit from it. Do not continue if they don't. They do not recommend any antioxidants, which I think is some ongoing studies looking at those, and there's not been found to be any benefit to using antioxidants. You should not use an antitussive on a regular basis for management of patients with stable COPD. That changes obviously with exacerbations. They do recommend phosphodiesterase 4 inhibitors in patients with severe disease, and this is roflumilast or, oh dear, I'm blanking on the brand name, Daliresp, for patients with severe disease or 2 or more exacerbations over the last 12 months despite triple therapy. They do discuss prophylactic antibiotics and recommend considering azithromycin 3 times a week, as long as the patients don't smoke, as long as their non-pharmacologic management has been optimized, and if they continue to have frequent exacerbations, prolonged exacerbations, or exacerbations that require hospitalization. They do recommend a sputum culture and airway clearance techniques, as well as a CT to rule out bronchiectasis and other pathologies. They would like a baseline EKG and LFTs, liver function test prior to starting. And then the risk, when these patients, there is a small risk of hearing loss, and then there is also a risk of increased cardiac death, which is why they want the EKGs to be done prior to starting. Continue to review after 3 months and then every 6 months, and as long as you're seeing benefit, which would most likely be decreased exacerbations, you can continue this medication. If not, go ahead and stop. They do recommend that you provide a non-macrolide antibiotic to keep at home for these patients, and then also recommend that you don't need to stop azithromycin during an exacerbation for these patients. So that's pharmacologic therapy for stable COPD. Any questions on that before we move on to non-pharmacologic therapy? In this section, they discuss long-term oxygen therapy, and this was probably the area that I found to be a little bit more different than what our guidelines are. So assess patients if they have very severe COPD or severe COPD, cyanosis, polycythemia, peripheral edema, increased jugular venous pressures, or saturations less than 92%. For diagnosis, you would measure an ABG on 2 occasions, 3 weeks apart, and you would consider starting the patient on oxygen if their PaO2 was less than 7.3 kPa, which is equivalent to 55 millimeters of mercury when they're stable, or if it is between 55 to 60 millimeters of mercury if they've got some other type of symptom like polycythemia, edema, or pulmonary hypertension. They do recommend that you conduct a risk assessment. Does the patient have frequent falls? Are they at risk for burns or fires from their oxygen? And if the risks outweigh the benefits, then they recommend not starting oxygen, regardless of what their saturations are. If they live with a smoker, you need to make sure that the smoker is offered smoking cessation advice and treatment, as well as referrals to specialists. And they recommend do not offer long-term oxygen to people who continue to smoke. Patients should wear their oxygen for a minimum of 15 hours a day. They do not recommend oxygen for patients that have isolated nocturnal hypoxemia. So if they only have low oxygen at night, they don't recommend starting them on oxygen. And then, as here, they should be reviewed at least once a year. Excuse me. Do not offer oxygen to people who have mild or normal oxygen saturations at rest. You can give it to people who desaturate just with exercise, as long as they're motivated to exercise and to use the oxygen during exercise. This is for ambulatory oxygen therapy, sorry. And then you can use it for patients who are already on oxygen at home and wish to be more active or get outside of the home. They do recommend that you have small, lightweight cylinders, oxygen conserving devices, and portable liquid oxygen systems, all available for patient selection. Non-invasive ventilation, you would refer people for evaluation for this if they are adequately treated but continue to have chronic hypercapnic respiratory failure and have needed assisted ventilation during a hospitalization. They recommend referring these patients to a specialist for further evaluation. In the interest of time, I'm going to sort of speed through this a little bit. So core pulmonal and pulmonary hypertension is defined as right heart failure secondary to lung disease, and their primary pathology is salt and water retention that leads to edema. They have edema, raised venous pressure, systolic parasternal heave, and a loud pulmonary second heart sound. They do recommend not offering medications for primary pulmonary hypertension to these patients, especially if their disease is caused by COPD, which is in alignment with our recommendations. They do recommend that they're offered optimal COPD treatments, control their edema with diuretics, and recommend not using alpha blockers, ACE inhibitors, calcium channel blockers, or digoxin if their core pulmonal is caused by COPD.
Allison, would you go back a second?
Sure.
Because that last point is one that we should really pay attention to, because that's widely ignored. So not alpha blockers, not ACE inhibitors, not calcium channel blockers, and not digoxin. I think we're okay on digoxin, but all the other categories we're seeing frequently in use.
Well, and I think part of it is, a lot of times in these patients, it's hard to determine whether COPD is the sole cause for their core pulmonal or whether they've got underlying heart disease as well. And I think that's where some of the use of these medications come in. So
yeah.
I think that might be part of the difference that we're seeing.
Yeah.
They do recommend pulmonary rehabilitation, make it available to all appropriate people with COPD, including those with a recent hospitalization for an acute exacerbation. Offer it to anyone who views themselves as functionally disabled by COPD, which would be an MRC grade 3 and above. So they walk slower than people of the same age on level ground, or have to stop for breath when walking in place on level ground. And pulmonary rehab is not suitable for people who are unable to walk, who have unstable angina, or a recent myocardial infarction, which I think we all are in agreement with that. For programs to be effective and to improve adherence, they should be held at times that suit people, which I know has been one of Grace Ann's big points, that we need to offer pulmonary rehab programs at times that patients can get to them, whether, if they're still working, we need to offer evening programs or weekend programs, that the buildings need to be easily accessible. They should have a spot within a reasonable time of referral. You would hate to refer somebody and then have them have to wait 6 months. You should have multi-component, multidisciplinary interventions tailored to the patient's individual needs. You should incorporate a program of physical training, disease education, and nutritional, psychological, and behavioral intervention. And patients should be advised of what the benefits of pulmonary rehab are, as well as the commitment needed to gain these. They need to know that they're going to have to put in the work in order to get the benefits. They recommend pneumococcal and annual influenza vaccines, lung surgery and lung volume reduction for patients with severe COPD who are non-smokers, who can walk at least 140 meters on their 6-minute walk, especially if patients have hyperinflation or emphysema on their CT scan, as long as they are on optimized treatment. Then these patients should be referred to a specialist for evaluation. Alpha-1 antitrypsin, remember they recommended testing for it for certain populations, but they actually do not recommend augmentation therapy, regardless of level of deficiency, which is something different than what we see here. So that's why I found that recommendation sort of funny, that they would test for it if they're not going to treat it. I think maybe just peace of mind to know why a 35-year-old or a 20-year-old has COPD. But they do not recommend augmentation at all, from what I've seen. They do recommend that COPD patients should have multidisciplinary management. You would need types of people who would be able to do the assessment, people that would provide care and treatment, people that would be able to advise on other issues, folks that would identify the high-risk patients, and then people that would provide education. And so they do recommend a physician, nurses, nutritionist, physiotherapist, all helping, respiratory therapists also helping with all of these aspects. For follow-up of these patients, recommend documentation of COPD in their chart, record their spirometry at diagnosis, offer smoking cessation resources, recording their spirometry over the next 5 or so years to identify patients that have rapidly progressing disease who may need a specialist referral. And then they recommend that these patients be reviewed at least once a year if they have mild, moderate, or severe disease, and every 6 months for patients that have very severe disease. So in the interest of time, I think I'll probably just stop right there and see if there's any questions. The last section talks about acute exacerbations, and I can always jump in with that sometime in the future if we are in need of a presentation.
Thank you so much for that. Wonderful didactic.
Sorry about the baby.
Well, more the merrier. So if anyone had any questions or comments about Allison's didactic, please feel free to ask us. You can also email us with questions after the fact, and we can pass them along as well. So, and Dr. Doyle, I was going to ask you, would you like to follow up with your case questions as well for the next time we all meet, for when you also do your didactic?
Sure, that would be great.
Okay.
And we might even resubmit this case with more updated spirometry data.
Perfect.
But yes.
Okay, wonderful.
So I think just a brief summary, I don't think that there's too much that's really different from the GOLD guidelines now that they've realigned the NICE guidelines, other than, like I said, the somewhat more paternalistic aspect of not giving treatment unless patients are willing to stop smoking. I'll just say that as summary.
Yeah, perfect. Thank you so much.
And I have a very quick comment, which is we had great representation today from the Dorney-Koppel Foundation with Grace Ann, who didn't speak, but she's there somewhere, and Kim Tiemann, who was on the line, and also Eric Stockton. And for them, one of the things I keep track of each time is participation of Grace Ann Dorney pulmonary rehab sites. And we think of 10 ever sites and 8 which remain active. And out of the 10, we had 6 out of 10 today. And out of the active, we had 6 out of 8. So that's pretty good.
That's wonderful. Thank you for that update and letting us know. All right. Well, just one announcement for everyone. Our next session will be on February 3rd. The January 20th one is canceled because it's Martin Luther King Day. So on February 3rd, we will be meeting again at 8 a.m. and Dr. Doyle is going to present a didactic on Catch My Breath vaping curriculum. And we will also follow up with the case questions and may have some updated spirometry information as well. So thank you all for joining us, and thank you, Allison, as well for the wonderful didactic. We will send out a recap email with more information as well, so feel free to email Caitlin or I. Thank you, everyone.
Thank you.
Bye-bye.